of pocket. Out of pocket is the money people pay at the point of service, when you're using the service. So that's one method of paying for healthcare, and usually the most undesirable method of financing health. People should not pay out of pocket at the point of delivery. If you're sick, you should not be worried of getting health care. The fourth method of paying for health, it can be performance-based. Maybe you can fix it up. Sometimes you can pay for us in the national government. Dr. Shikeli will tell you, we pay on base, especially for me in the transforming for UHC. For certain parameters, we pay the county some money. So you can pay based on performance also. And lastly, I think Dr. Shikeli mentioned also, external resources can be used to pay for health, isn't it? You can get a donation that can help you to expand your health services. So external grants can also be used to pay for health. So this is Prof's slide. Mine is less colorful. Yours was very colorful. This one is plain. Prof's was with a nice blue background, isn't it? What is universal health coverage? Sorry, I think we have a problem with the projector. Maybe you can connect again. So I think it has been mentioned by Prof. I just wanted to show you the WHO diagram. When you talk about universal health coverage, it has three components. It's called the UHC cube, Universal Health Coverage Cube. This is the cube. It's about three things. First, you know, how many people are covered. Coverage is how many people are covered, you know. The second part is what are the services covered. You can cover everybody with one service, isn't it? So it's how many, you know, how many people are covered, how many services are covered. And then the third thing is, of course, the most thing known for UHC is the financial protection. How people are protected from undesirable expenditure, what Dr. Shikeli was calling catastrophic health expenditure or impoverishing health expenditure. So these are the three things in the cube. So the aim of the government is, or any government in terms of UHC, is to fill the smaller cube to make it equal to the bigger cube, which is the, you know, the ideal. You want to ensure as many people as covered. You want to ensure, too, as many services as possible are covered. And the third, you want to ensure that there is very little out-of-pocket expenditure. So those are the you know, from the perspective of UHC, that's what we can talk about. For Kenya, I'll not give this, but we have set the UHC agenda, the presidential agenda of Big Four. The aim is to make sure by 2018 to 2022, we have at least 100% coverage. I'll explain what that means as we go on. So the first thing is to, as we talked about, in the pilot counties, I think of Machakos, Nyeri, Isiolo, and Kisumu, which we are starting now. We have provided, we selected what is called a health benefit panel that was eminent Kenyans who are chosen to decide what coverage, what services should be given to Kenyan. And they came with this type of services. Compared to NHIF, there'll be now more emergency service, which is a new service that will be provided to Kenyans. There'll be mental health. Of course, mental health has been forgotten, but now it will be provided to Kenyans under the UHC. Non-communicable diseases, I don't need to overemphasize on this. The whole morning we are talking about cardiac and renal, isn't it? So you can see now it's coming to non-communicable diseases, and maternal health services, which will also be enhanced, child health services, and lastly, major infectious disease, which also will be enhanced. So the UHC coverage benefit package will have more enhanced services than what we're getting now. So what has been adopted by the government towards UHC? Government of Kenya here, both together with the counties. I think it has been mentioned about the approach. I want to use the scientific terms for you to know which method we are using. So there's a big bang approach where you want to do everything for everyone. That one we call it the big bang approach. The second approach that the country is adopting is called progressive universalism. You are moving towards universal healthcare progressively. So you start from, you know, you segment your population in the progressive universalism. You decide what you want, the services that you'll start with. So Kenya has not picked a big bang approach where it will go for everybody. We are going for progressive universalism. So what have we done? What is progressive universalism here? It has already started. For those who know, there was abolition of user fee in primary health facilities government many years ago, and the national government now is funding counties, is paying for them not to charge providers. That's already started. Of course, the Linda Mama, the famous or infamous Linda Mama, that is already there, and I think people are not happy with what they are getting, but it's already being provided. That one is targeting the pregnant women. We also have the level 5 grants. The government is giving a conditional grant to level 5. I think Dr. Shikeli can confirm at least that one is coming. We're giving some money to Coast Hospital, Coast General Hospital, soon to be Coast National Hospital. Yeah, next, I think also through different programs, the government is also providing 22 billion Kenya shillings towards the UHC agenda, as I said. So in 4 counties, how much money is available? So first of all, in the pilot counties that I've talked about, there's already money there that is going to support the counties. We have, if you look at Nyeri, there's already half a billion. So half a billion shilling there. And if you look at Machakos, you'll see they have 492 million that they already have received as part of the UHC agenda before we go into the new agenda. So in terms of the pilot, where will the money go? And I think Prof talked of primary health care. This one is already showing that our priorities are upside down somehow. So the pilot, we have divided the money that we are doing in the pilot into these percentages. Community services, which is mostly primary health care, is 2%. Basic and specialist services, 80%. That's the majority of the money that in the UHC will go to basic and specialized services. Health system strengthening, employment of new health workers will take 17%. Public health services will be 0.0. So public health and community health, we are using less money, not because it's not a priority. Luckily for us, we know that prevention and promotion health services is very cost effective. It's cheap compared to what we had in the morning, isn't it? 500,000 and above per procedure. So we know that immunization costs maybe 5 shillings per person. It's very cheap. So that's why there's less money invested there. So in terms of roles and responsibilities, universal health coverage agenda that is in Kenya has many players. We have the national government, we have the county governments, we have the private providers, we have associations like KAMMP also who have a role, which I'll explain later as one of the things that we can look at. So lastly, I think, yes. Yeah, we're told now the guest of honor, I think, is about to leave, so I'll just rush back, take you through maybe the last, maybe the policy considerations. As a country, we have done a pilot. We have to decide, I think, whether moving forward, UHC should be something contributory or non-contributory. Right now, we know UHC, the way it is piloted in the 4 counties, is non-contributory. For non-contributory schemes, it's very expensive because the money has to come from somewhere if it's not coming from the people. The role of the 2 governments also has to be clarified, the role of public and private sector, and also issues whether it will go for NHIF will have a role in the UHC in future, because as of now, the UHC agenda, the NHIF does not have such a big role. I think before I close, I have 2 issues that I wanted KAMMP to look at. It's a bit controversial, but in terms of the policy space, we invite faith-based organizations in the policy space for discussion. And at the moment, I think we really need, Prof is here and the others, we really, and Chairman, the representation of the Muslim community in the policy space in the country has to be really cleared, especially between the 2 major organizations. Now we have KAMMP, but what we are seeing now, mostly the policy space, in the policy space, the representation is done by SUPKEM. So that has to be looked at so that the representation of the Muslim community is as effective as possible. Thank you very much. Wassalamu alaikum.
Thank you very much, Dr. Umar. When I was looking at the program, I see you've chained of your CV will possibly run to 60 pages. Ladies and gentlemen, that's one of the reasons that Gideon Douglas came out of here is because you're not a doctor. All the people who are seated here are doctors, including Seth, though he's not a medical doctor. The other day, I learned this when the county government was launching the Huduma Kwanza program. I was there in the evening, and it's part of the initiative that one of his brain child program was, I mean, go to the website and you learn about that Huduma. But I welcome all of you to this conference. And after the East, I hope you'll enjoy the nice atmosphere and facilities that are there in Mombasa. But I wish also to recognize that actually the county government of Mombasa has done a lot to improve medical care. The governor, in his personal capacity with his friends and also the government, they've done a lot to improve that. And here I know we are gathered, you know, people from Dr. Umar from the national government, and also NHIF to discuss about this important matter of UHC. But UHC and health in this country will not be done if doctors are not paid adequately. In fact, when you look at one of the SDGs, Sustainable Development Goals number 7, is to have paid well and empower them. But what everybody is trying to do, you are saying you cannot cost medical services. A friend of mine is an architect in Nairobi. I asked him to go and look after a property. You know, at the end of the day, he sent me a nice bill that to drive from Westlands to Langata, it took me so many hours, it will cost this much, and I spent so many minutes to do this, and after that I add my professional fee, it was this much. I don't know why it's very difficult for you to cost health. I mean, these doctors are working at night and spend so many hours, but UHC, and one of the things that is important is to improve access. And you cannot always be developing doctors. It is only your charges. While I know everybody else, even NHIF, it will pay our legal friends 70 million, 80 million. We see it in the papers, or 200 million for works that sometimes have not even been delivered. That is all a discussion for another day. Without much ado, I had a 10-page opening speech, but I'm going to shorten it to that. I will take this opportunity to welcome Dr. Seth Odongo, who is the CEC in charge of devolution, and he's here representing both his colleague in health and also the governor. Welcome.
The chairman, Kenya Association of Muslim Medical Practitioners or Professionals, Dr. Ramadan Marjana, that's correct. The Secretary General, Dr. Rajab, the Project Director, Dr. Ahmed Omar, the County Chief Officer of Health, and my colleague, Dr. Shikeli, distinguished consultants and professors, led by Dr. Abdallah, Professor Abdallah, if I'm right, all doctors present and nurses amongst us, distinguished guests, ladies and gentlemen, good afternoon. Good afternoon again. I'm happy. Sorry, I've also noticed my colleagues from NHIF And it would have been very, very bad, in bad taste, not to acknowledge them. Yet they are one of the very important stakeholders in this seminar. I bring the greetings of my governor, as well as the message of goodwill from him, His Excellency Hassan Ali Joho, my colleague Hazel Koitaba, and the entire county government of Mombasa. We are really very happy to have you choose our county to be the place that you are holding the 3rd conference, because that means a lot to us. By the time you're living here, many people will be assured of getting their salaries because of what you'll spend here. Many business people will be sure of being paid their dues, whether they supplied vegetable, eggs, and very many other things. So we are very happy. We are delighted. It means that on this particular day, you have really contributed to the economy of Mombasa County. And we hope that in the near future, you will still make it the place to hold your conferences. I want to join in congratulating the Kenya Association of Muslim Medical Professionals, because if you look at the theme of why you are here today, the universal health care, part of the reasons why we have not been able to achieve that progress is because of faith. And Dr. Omar has alluded to that. A lot of controversy. There are some many faiths, maybe not the Muslim faith, that have some serious issues to be looked into, because some aspects of their faiths try to prevent people from accessing universal health care. At the end of the day, we are not likely to achieve that unless we have a special way, a special association that is capable of looking at all issues surrounding medicine and access to medical services within the faith like the Muslim faith. It's also important to recall that this particular initiative, the universal health care, is not something new. When we became independent as a country in 1963, part of the challenges that were given priority was health, kupigana na magonjwa. Others being ignorance and what? And poverty. True? And very many years after that, it's a pity that not many people are able to access medical services, either because they are exorbitantly costly or because the distribution of health facilities across the country may not be that convenient. But with the universal health care, or to borrow from my colleague Dr. Ahmed Omar, universal health coverage, we have a new opportunity for everybody to access health services. And of course, the finances, partly being the insurance agencies like NHIF, play a very important role. But to me, my contribution that I will give today, and which will depart from anything to do with discussion on anatomy, pathology, or even morphology, because I'm not a professional in that particular field, will take the direction of the business approach. If universal health care is to succeed in Kenya, then the medical fraternity, as well as the insurance, health insurance, should be able to look at three key things. And it's not very far from what our previous colleagues have talked about. The people or personnel element. And that's where you doctors and nurses also belong. unless we invest heavily in highly skilled professionals who are able to give quality medical interpretation, prescriptions, and very many other things, then even with insurance, nothing much will take place. So we need to motivate our doctors, our nurses. You may not know how important they are until you lose them. So even as somebody in charge of public service, I would want to contribute to helping my governor leave a lasting legacy, because healthcare is part of that particular area for which he would want to be remembered. If you look at the Coast General, and we've talked about it over and over again here, and for which even my colleague stands very tall, this lady by the name Dr. Hadija Shikeli will go on record as a very hardworking lady, as a lady who has made a lot of contribution in that particular field. Of course, not forgetting Dr. Kandawala and also their CEC. People element must be looked at. I'll not take much of your time because I know what the weekend means. I also know what 1 o'clock means. I also know what this program carries. So the more I talk, the more I'm consuming your time. So I'll be very brief. The second thing is the facilities. They need to be improved. And when I talk of facilities, it's not just the buildings only. We are talking about the equipment, we are talking about medicine, and we are talking about the physical environment. So that even as people come to access the health services, the site of where they are treated becomes the first step towards healing. Because sometimes you can go to a hospital setup, then looking at the way the patients themselves are dumped, in fact, you start writing your own obituary even before you are being treated. So the best thing also is to look at these facilities and see how best they can be able to promote the healing process. And for us, like my colleague has already talked about, we are trying to make them as elegant as we can. And today, if you go to Coast General, if you go to Mrima, and the ones which are upcoming, you will confirm that indeed we are serious about making the environment very conducive. And that will also remind me very quickly that even Kenyatta Hospital now is really very good. If you have gone there of late, it's very good. Finally, to the financials. Again, there is something I would want to comment on. I heard my colleagues say that you cannot be everywhere at the same time. To me, I think that is what you need to work on, so that actually you can be felt everywhere. And the best way to do that is to take a three-dimensional approach. Take people to the institution where a majority really need your services. Places like Coast General, places like Kenyatta National Hospital, places like Mombasa Hospital should at no time not have somebody representing NHIF. They should be there. Secondly, you can also partner with other organizations that can do those on your behalf. Again, you can also improve the online services by making them fast, reliable, and updated at any given time that people would want information. With that, you will always be everywhere. And to Mzee Abdallah, our great professor, there's a small thing I want to correct. You say you intimated that Mombasa County, big as it is, can only employ 2 interns. The truth of the matter is that we employed 21, not 2. So we are doing very well, and in the near future, we'd want to make sure that we even double or triple that particular number, because we know very well that our future depends on doctors, and you are one of them. And as an individual, my parting shot is that doctors, we really love you. because minus you, we only depend on God. Thank you very much.
So thank you very much, Bwana Waziri and Daktari. We really appreciate you coming. Thank you very much. Thank you. Next, we will go to our very important guest, Dr. Kasim Sezen. Dr. Kasim is the president of World Islamic Health Union. They're based in Ankara. They have over 70 member countries. And one of our representatives from Kenya, Dr. Zahra, seated here. She's one of the council members for World Islamic Health Union. And as Kenya Association of Muslim Medical Professionals, we are part of the coordinators team of World Islamic Health Union, and we are in charge of social affairs. So without much further ado, I would like to ask Dr. Kasim Sezen to give a small presentation of what World Islamic Health Union is, and the projects that they have done and what we hope to do in the future, inshallah.
Thank you, Abdullah. Esselamu Aleyküm ve Rahmetullahi ve Berekatuh. Muhammad Emin, come. In this here, I have got my brother, my friend, my sister, Dr. Abdullah, Dr. Süleyman Bakari, Zahra Ali, Dr. Dr. Gulam, Dr. Selma Naji. After Turkish.
You will continue in Turkish after this.
Biz 3 yıl önce sizin buradaki temsilcileriniz, bu saydığım arkadaşlarla beraber kamp olarak İstanbul'da Dünya İslam Sağlık Birliği'ni kurduk.
3 years ago, we were honored to have received members of the KAMMP organization to come and visit us in Istanbul, and together we formed the WIHO organization.
Dünya üzerinde Müslümanların kurmuş olduğu bu organizasyonlar, bu dernekler, vakıflar, tabip odaları, bunların bir birliğe ihtiyacı vardı.
We saw that there was a need for Muslim organizations from all over the world to come and be united and form such an organization together.
Ve bunun üzerine bu Dünya İslam Sağlık Birliği kuruldu. Bugün Allah'a şükür 110 ülkede 350 sivil toplum kuruluşu üyeye ulaştı. 350.
And during this process, we were honored to have around 350 members from all over the world, all over the Muslim Ummah, and from 110 different countries around the world.
Sağlık sektöründe Müslümanların eğitimi, ekonomik olarak işbirliği ve birbirleriyle kenetlenerek sağlık yardımı, insani yardım götürülmesi hususunda WIHO üyeleriyle beraber çalışmakta.
WIHO works with its member organizations to strengthen the relationships or the relations between Muslim countries economically and in the health sector, to bring all these countries together and work towards a strong Islamic union.
Bugün burada Kenya'daki sigorta sisteminin gerçekten belli bir seviyeye gelmesi beni çok sevindirdi.
I was very happy to listen to and learn about the Kenyan NHIF system, which is a system also based in Turkey, and I'm very happy to learn about its success in Kenya as well.
Buradaki Kenyalı kardeşlerimin hepsini çok seviyorum. Onlar için ne yapabiliriz? Biz de bu hususta kafa yormaya geldik.
I love actually, sorry, not like. I love each and every one, around 4 million from Syria who live there as refugees. And each and every one of these residents of Turkey don't pay a single cent when they go to hospitals to get treated.
Bunu Batılılara anlattığımız zaman diyorlar ki siz aklınızı mı yediniz, şaşırdınız mı, çok mu paranız var? Biz sosyal devlet olma hedeflerimizden vazgeçiyoruz. Siz sosyal devlet olma yolunda son sürat gidiyorsunuz.
Whenever we explain this system to Western countries, they always tell us, have you guys gone crazy? Why are you going towards a social government when we are running away from one? Why are you trying to do this?
Bugün Amerika'da paranız yoksa sokakta ölün diyorlar.
In America right now, or today, if you don't have money, they tell you to just go die on the streets. You don't get payment basically from the government.
Diyalizin ücretini ödeyen dünyada çok az sayıda ülke var.
There are very few countries in the world who the governments pay for dialysis.
Burada Malezya var. Malezya Kenya'dan belki 5 kat, Türkiye'den belki 2 kat daha zengin bir ülke ama diyaliz ücretlerini ödemiyor.
The country of Malaysia, which is actually maybe it might be 5 times more rich than Kenya, or maybe twice as rich as Turkey, but they don't pay for dialysis operations in hospitals.
İnşallah Kenya bu yola girmiş, bu yolda devam etmesini istiyoruz. Maddi imkanı olanlar tabii ki ceplerinden bir miktar ödesinler. Ama fakir olan insanların mutlaka devlet sağlıklarını karşılamak durumunda.
The government needs to actually take care of the rich as they do the poor, and I'm actually happy that Kenya is going through that route to make universal health coverage a necessity for each and every resident of that country itself, of the country.
Hükümetlerin işi güvenlik, eğitim ve sağlık. Eğer ki bunları da yapmayacaksa bu hükümetler niye var?
The purpose of governments is actually to provide for security, health, and generally suitable place to live for its population or its citizens. If that's not the purpose, if they don't do this, so why do we need governments?
Ben burada sözlerimi bitiriyorum. Hepinize çok teşekkür ediyorum. Burada Kenyalı kardeşlerimizin, Müslüman kardeşlerimizin böyle güzel organizasyonları yapmasından dolayı çok mutluyum. Hepinize teşekkür ediyorum. Allah'a emanet olun. Esselamu Aleyküm ve Rahmetullahi ve Berekatuhu.
And that's all I wanted to say. I'm very happy and I'll be here inshallah for the next 2 days. Thank you very much for inviting me to this event. And I wish you a successful event in the next 2 days, inshallah. Have a good day. Allah'a emanet olun. Assalamu alaikum.
Thank you very much, Dr. Kasim. Teşekkür ederim. Next we will go to our next speaker. We kindly ask of you to give us some time allowance because we have some speakers who have some emergencies tomorrow and they've asked to be brought today, so the program had to be extended a little bit. So without much further ado, we will go to our colleague, Dr. Mzee Gunga. Please come to the stage. He's an interventional cardiologist at the Aga Khan University Hospital, Nairobi, and he's the head of the cardiac training fellowship. Karibu, Daktari.
Thank you, Dr. Payaba, and thank you to the committee that has organized this meeting. I'm really sorry to be the one standing between you and your lunch. So I don't even know why this session was brought here after such an interactive session about healthcare, universal healthcare, but nonetheless, I'll try to make it as brief as possible to try and understand why we have to prevent sudden cardiac death. I was making a joke about some video which was making rounds in the media recently about someone who was being resurrected. So hopefully after listening to this talk, we can look for ways of preventing those kind of scenarios where other people have to get the credit for what the doctors are doing better. So I'm actually giving this talk on behalf of my colleague, Dr. Mohammed Jelan, who is not here. So on your program there, it may read Dr. Jelan, but I give the talk on his behalf because he's busy somewhere. Hopefully this is going to work. So, prevention of sudden cardiac death is kind of a complex topic, difficult topic, and indeed, as I'm talking about it, I'm going to talk in the context of cardiology, because sometimes in cardiology, unfortunately, we are faced with the task of holding life at the very death of it. So, once in a while, we are called to the hospital, things have gone awry, and whether it's from gynecology, whether it's from surgery, whichever department, sometimes the doctor just has to be in there to do whatever needs to be done to get the patient back to life, and then the doctors can treat the primary problem. As far as cardiovascular causes of sudden cardiac death are concerned, this is a very good study looking at what are the causes of sudden cardiac death in young people less than 35 years of age. And interestingly, you probably guessed it right, but the commonest cause of death, sudden death in young people, is indeed hypertrophic cardiomyopathy. If you look at that closely, and you'll be surprised, the next common cause indeed is anomalous coronary artery. So these are post-mortem diagnoses. These are young men, footballers. It always shows up in the news. Someone who's practicing for football, or rugby players, young men. And interestingly, some of them are indeterminate left ventricular hypertrophy. Some of times when you are looking at your patients and you see the ECG or the echo saying left ventricular hypertrophy, unfortunately we see these patients occasionally. So left ventricular hypertrophy just happens to be one of the causes of this. And whether these are undifferentiated phenotypes is something worth discussion. Oh, I don't know how I can make this better. Keeps playing around with this. Maybe we can lose connection somewhere. Okay, hopefully that's going to work better. So, yeah, so this is just a slide which I thought is worth sharing. And again, if you look at cardiomyopathy or heart muscle disease, there are many types, and the most common that we see here is dilated cardiomyopathy or idiopathic type. Then we do have hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, left ventricular and compaction restrictive cardiomyopathy. So this is interesting because if you really look at that whole list, one of the commonest causes of death is actually hypertrophic cardiomyopathy. And interesting, it's not the commonest cause. Probably accounts for a very small number of the cardiomyopathies, probably less than 1%. But indeed, the problem is diagnosis. Most of these patients now present suddenly as acute cardiac death in an event, someone's in a sports and that kind of activity. And then that's the time you make the diagnosis. Occasionally, these people are discovered incidentally when you are doing ECGs. The other channelopathies, which also follow the cardiomyopathies, and they may cause sudden death, and these are important, such as the Brugada syndrome, long QT syndrome, short QT syndrome, is idiopathic VT, and something called short coupled Torsades. Torsades is not uncommon, but sometimes it can be drug-induced. So people may have long QT syndromes, and then they take some drugs to prolong their QT. And this is sometimes the only way you can diagnose these conditions. And as I'm talking about prevention of sudden cardiac death, there are two types of preventing sudden cardiac death. One of them is using medications. If you treat your patient with medication for cardiomyopathy, that can help prevent sudden cardiac death. But what has been shown to improve mortality significantly is the ICD. ICD stands for implantable cardioverter defibrillator. It's a small device, it's put in the front of your chest, and it can help prevent sudden cardiac death induced by ventricular fibrillation or ventricular tachycardia. So hopefully at the end of this talk we can understand what is the primary and secondary prevention of sudden cardiac death, because I think that's a kind of what's important to the audience. The review of evidence of ICDs. Are these ICDs useful? Do they really prevent sudden cardiac death, and how useful are they in your patients? What are the guidelines for ICD use, and understanding of the above using a case vignette? Hopefully that will take us to 2 p.m. and our lunch is just going to be consisting of prevention of sudden cardiac death. So what is primary prevention? When it talks of primary prevention of sudden cardiac death, it means this patient has never had an event. This is a person who is at risk. The person may have a cardiomyopathy. The patient may have had a long QT syndrome. The patient may have had a family history of sudden cardiac death. So the purpose of primary prevention is to prevent an event when the patient who has never had any acute illness. So these are people who have cardiomyopathy or heart failure, post-MI patients, hypertrophic cardiomyopathy, long QT, and Bullgara syndromes. Whereas secondary prevention is a group of people who have already been resuscitated from an event, such as VT or VF. And usually this is outside the setting of acute coronary syndrome. So these are patients who have survived an acute cardiac event and therefore they get resuscitated. And sudden death is not uncommon. This is something I picked up from a newspaper also. So on Friday at around 9:30 p.m. he was seized by cardiac arrest, heart failure. Unfortunately, those who are not doctors have their own ways of interpreting what happens in front of them. And was promoted to glory at around 10 p.m. He passed at the age of 75 years. He left behind blah, blah, blah, blah. These are people who are apparently healthy. And someone goes somewhere and just like that, they are gone. What causes death in these people? This particular patient, interestingly, the post-mortem showed an acute myocardial infarction. And indeed died of a large MI, 75-year-old man. How common is VTVF? This is a study which we published in our hospital looking at how common these two scenarios are. And if you look at this study, it showed that the commonest, the rhythm which is associated with highest survival is actually VT and VF. So indeed, the commonest rhythm abnormality in the cardiac arrest situation is actually a systole followed by a PEA. VF, VT contributes to a smaller number, but these are the patients who have the highest likelihood of developing risk. Most of them, approximately 58% of them, will develop return of spontaneous circulation after resuscitation, as compared to 17% and 40% of those develop PEA. And when you look at the multivariate analysis of survival, those who get return of spontaneous circulation, indeed, development of VF was an important finding for the development of return of spontaneous circulation. So ICD is really worth it, and we have enough evidence to support the use of ICDs. There are a couple of studies, and if you look at this literature, this is literature which looks at secondary prevention of ICDs. These are people who have already survived VF, VT, and these are studies which were performed in the late, in the last millennium. Some of you may not have been doctors. And what they showed that they actually reduced mortality by as much as 31% and 23%. And this is based on this evidence. Actually, you may never see any new studies looking at the role of ICDs in secondary prevention of sudden cardiac death. The area which is of most debate is primary prevention. And those people who are at risk, do these ICDs actually reduce mortality? So if you look at the literature here, mortality actually does reduce in a certain group of patients. If you look at this particular graph here, which is very busy, if you look at the MASSI trial, they look at people who have an EF of less than 40%, who have coronary disease, they have non-sustained VT, they have induced VT on EP study. There was a 51% reduction in total mortality if an ICD is implanted. If you look at the MADI-T trial, which was done in around 2020 or 2, there was a 30% reduction in all cause mortality with an IC therapy, if it is put in people who have an EF of less than 30%. These studies were conducted over and above usual medical therapy. That means if you put an ICD in your patient, indeed, you can actually reduce mortality. Look at the latest study done in 2005 called the sudden cardiac death heart failure trial. They enrolled 2,500 patients, EF of less than 35%, heart failure, functional class 2 to 3, and both ischemic and ischemic cardiomyopathy. Overall, there was a 23% reduction in overall mortality in ICDs. So what ICDs do basically is that they cardiovert the terminal VF or VT rhythms, which are kind of common in people who have heart failure and ischemic heart disease. So if these patients are at a high risk for this particular event, it means they are the ones who are most likely to benefit. And that's why if you look at this particular chart here, it applies a lot to people who have heart failure and cardiomyopathy, and particularly so if the cause of the cardiomyopathy is indeed ischemic cardiomyopathy. This is just one of the trials that I picked up, the multi-center automatic defibrillator implementation trial, 1,232 patients, more than 1 month post myocardial infarction. There was a reduction in mortality by 31% with ICD therapy, and that finding was indeed significant. The SCD trial, the sudden cardiac death in heart failure trial, again, they looked at patients who had heart failure, functional class 2 to 3. These are people who have symptomatic heart failure. So these devices work particularly so in those people who have symptomatic heart failure and in the setting of cardiomyopathy. And the EF commonly has to be less than 35%. These people must be on the conventional therapy. So over and above these devices, if you look at this particular study, they gave one group conventional therapy for heart failure plus placebo. The second group got amiodarone, which is an antiarrhythmic drug, and the third group got conventional treatment plus conservative programmed shock only ICD. In this particular group, there was no survival benefit with amiodarone, but there was a 23% reduction in overall mortality with ICD therapy. And there was an absolute reduction in mortality of 7.2% after 5 years in the overall population, which was studied in this particular trial. These are a couple of other studies looking at this particular topic. I think I'll not belabor a lot on this, but I'll show one particular case of a patient. Let me go back. Yes, Gregory, 48-year-old man, non-ischemic cardiomyopathy. He has come to your office to discuss the possible placement of an ICD. ICD, again, is an implanted cardiovascular defibrillator. He has alcoholic cardiomyopathy, 5 years now. He's been off alcohol for 5 years. During his hospital stay, an echo showed an EF of 30%, and the cardiac evaluation showed no clinically significant coronary heart disease. At discharge, he was on medical therapy in the of 20 milligrams, carvedilol twice a day, spironolactone, and furosemide, all good therapy for heart failure. So this patient is on good medical therapy and has come for subsequent follow-up. When you talk to him, he's good adherent to his medication. He's asymptomatic at rest, but has dyspnea when he climbs a flight of stairs to his office. What functional class is that? Someone who can get dyspnea on climbing stairs to their office. So many doctors will put him on functional class 2. The ECG shows no more sign of pain with a QRS of 90 milliseconds. And the repeat echo 1 week before the visit is unchanged from the prior one. So during Mr. Gregory's hospital stay 6 months ago, you had discussed with him the possibility of implanting an ICD. He's concerned about the invasive procedures and hesitant to proceed with intervention unless he's convinced they are necessary. He has had ICDs deliver inappropriate shocks, and he mentioned to a friend who recently had an hematoma after pacemaker placement. He wants to live as long as possible with a good quality of life. I would like to prevent hospitalization. So, would you proceed to put an ICD or no? Do you think you would qualify for an ICD, this patient? Who says yes? Who says no? So it's a typical patient, and the question is, does he qualify for an ICD? So if you look at the evidence in the literature, ICD therapy may be considered in patients with an ischemic cardiomyopathy, EF of less than equal to 35% or in functional class 1, and they get a 1B recommendation in non-ischemic cardiomyopathy in an EF of less than 35% who are functional class 2 or 3. So assuming this gentleman is functional class 2 because he stops in climbing one flight of stairs, he probably gets a 1B recommendation for an ICD. So he's asymptomatic at rest but has dyspnea when he climbs a flight of stairs to his office. And again, this is just some of the evidence showing that an ICD may reduce mortality because he wants to live. Are the complications high? The answer is no. I think the complication from these devices is less than 1% out of the population which have been looked at. And indeed, I think for the sake of time, I'll probably stop there and I'll take any questions from the audience. about the ICD therapy in prevention cardiac death.
Given the lunch vouchers, please make sure you do not leave the hall without the lunch vouchers. Otherwise, there's no lunch for you. So, 2 minutes of burning questions. There's also a form going around for those who are interested in attending our dinner, or what we would like to call our founders' dinner, inshallah. We want to appreciate KAMMP founding members. So please, if you can attend, please do. Any questions to Daktari? This is the only time you're going to be able to ask him a question. I've met him several times in the corridors of Aga Khan, and
this must be a sense of hunger. As I'm sitting here, I have to appreciate my teachers, mentors, Dr. Hooker. I can see him over there. I had not seen him when I started, Dr. Ahmed Tahir. And indeed, if there are no questions, it was either very well understood, or indeed I'll have to come back here again tomorrow and present this talk. But nonetheless, I'm really delighted to be here in this association of Muslim doctors. I think it's indeed a very good initiative. And I was actually very delighted by some of the speakers who gave their talks about the UHC and how the counties are working to deliver health care to our people. And indeed, it's very, very impressive for me. So thank you very much to you all. And indeed, if there are any questions, you can all please hand them over to the team, and I'll be happy to come back any other time.
Thank you very much, Daktari. So a few announcements, please. The lunch vouchers, make sure you have them. We're going to hand out some numbers, vouchers with numbers 1 to 10. This is for the practical session. So if you're number 1, you're going to start with the skills session number 1. This is because we want everyone to rotate in all the skills sessions. So number 1, after about 20 minutes, we'll move to number 2. There'll be someone there to guide on how we move from one table to another. We have 10 stations, so about 15 to 20 minutes each. Please make sure you have all those numbers. The other announcement is prayers. We're going to pray in the next hall, yeah, Arabuko 2. We're going to have Jama'ah. I think the rapporteurs and the other organizers will arrange on where the ladies will pray and where the gents will pray. So those are all the announcements for today. There will also be afternoon tea after the program. So when you're done with the skills session, there's afternoon tea. Please don't go without having the tea. It's already paid for. Yeah. Unless there are any questions, I think. Please just 5 minutes so that you can have the vouchers and the numbers for your skills stations, please. The skill stations will be the same room that we're going to have the prayers, yeah? The next hall. So after your lunch, please proceed to the skills station. We're going to start probably at 2:30. Let's try 2:30. We have about 40 minutes. The gala dinner will take place in this hotel. We're going to have a beach setup, or they call it Swahili Street. So please do not miss. Register your name in those forms, please, so that we know the numbers. The ladies' prayer room is downstairs, a room called Kaya. Okay? Clarification, ladies' prayer room, downstairs, Kaya room. Dr. Salma, Dr. Azra will guide you. Please, please do not leave without the vouchers. And we use the stairs to the right.